Hey, this is Dr. C. Thank you for joining me today. We're going to have an interesting topic today. It may be a little bit long, maybe a little complicated, but nevertheless, it's an interesting topic that influences all of us, especially us seniors. And that is paying for our prescriptions. So, interesting topic. Should be simple, but it sure as heck is not. And it's not easy to find out exactly how all these things interact between the doctor giving you a prescription and what you're paying for it at the pharmacy. Should be direct line? No way. So let's deal with it. Let's deal with it. As a prelude, I'm going to quickly go over with you the whole big picture of the cost of healthcare. It is terrible. It is terrible because it is not a right. In fact, healthcare is only a right in the United States for the politicians. That is it. You say, well, what about the VA? Yeah, you could join a VA as well. The system is not as much of a right as it is on paper, but it is for the politicians. I want you to know that right up front. And so what is it about our healthcare system? It's the most expensive in the world by far. And we pay roughly for healthcare $48,000 per person on an average. $48,000 a year on an average. Well above what anybody else in the world pays. Well, we get a lot out of it, don't we? Yeah, we get a lot out of it. But what are the results? What are we getting really from it? Well, they've done studies on this. And when the United States is compared to all the other countries, not third world countries, but all the other, you might say, higher price countries, basically, we ranked out of the 36 countries that they analyzed in quality of care. The results, we're 26th out of 36. That's how great we are with the care. Infant mortality in the United States, we are 51st in the world. 51st, our country. Oh, so let me tell you, we got a long way to go. But this is specifically about the cost of healthcare. What I am going to do is I'm going to refer to the chart that I'm going to use. This is a chart that was done by a person called Aaron Trish, and it's called the adaptation of the flow of money for healthcare. And Aaron presented this as a kind of an expose of everything that was involved in the cost of health prescriptions in the country. And I looked at a lot of different schematics in preparation for this. This was probably the best of all of the schematics. Okay, let's start right from the beginning. You got yourself a prescription, and it's for a particular drug. First of all, how does your pharmacy get the prescription? Well, first of all, there's a manufacturer. Now, that manufacturer could have been the one that developed it, and then they're manufacturing it and then selling it. They could do all three. Most of the time, it's smaller places that have developed it. The bigger place, the pharmaceutical place, buys that for them, buys it from them, and then manufactures it. Now, they sell it in turn to a wholesaler. The wholesaler has a warehouse where they store all this. that sale, you might say, is dependent on a couple of things. Number one, the list price that the pharmaceutical house puts on that drug. A list price. Every year they have a list price for all their drugs. They negotiate with the wholesaler what the wholesaler is going to pay the pharmaceutical house. That's based on many different things, the volume that are sold, a number of different things that will affect the price. So that's one spot that's going to affect the price. So the wholesaler gets it and they put it into their warehouse. Now that has to be distributed to all of the pharmacies. Now there are specific wholesalers, specific distributors. They're decreased numbers now, probably only about 50 of the wholesalers left in the United States, and probably only about 15 or 16 distributors. A lot of them now are consolidated. They're wholesaler and distributor. The distributor then gets a call from the pharmacy, and I need to buy that particular drug. Okay. And now the distributor sends it to the pharmacy. What do they do? How do they make their money? They put on roughly about a 4% profit on what they send to the pharmacy. Okay. But it does affect the cost. Now, let's talk about the other end of things. That person, that patient who has that prescription usually has a health plan. They are members of a particular health plan. Now that health plan could be with their employer. So that's an employee health plan. Okay. And the employer is paying for part of the drug. Okay. Maybe part of the benefits that the patient gets as a result of being an employee of that particular employer. So I'm a member of that plan. That plan is there not for your benefit, but to make a buck. And remember that. All of these things are out to make a buck because, remember, health care is not a right. It's a privilege, but it's treated in this country as a commodity, like oil and all the other commodities. That is the way it is treated in this country. The hell with the right, the hell with the privilege, it's a commodity. Okay, so at any rate, we're at this stage now. The insurer wants to make as much out of this as possible, so they hire a benefit manager. Actually, they may hire two. One will be to manage all of the procedures that are done on their patients. So it's a kind of a procedural or a medical benefit manager. We had a program on that, Evernorth. We had EverCore by Evernorth. And we mentioned that. We call that program, denials for dollars, because they control all of the approvals, prior approvals, and denials. Okay, that's the medical benefit manager. But they also now have prescription benefit manager, PBMs. That's the one we're talking about specifically. They make several negotiations along the way that affect the cost of that prescription. Now, remember, the supply chain goes through the wholesaler, from the manufacturer, wholesaler, distributor, pharmacy. Okay, that's the distribution. And now the pharmacy is going to pay a specific amount now to the wholesaler, not the distributor, the wholesaler, or the combination of the two. They're going to pay for that prescription. They will also add to that, the pharmacy, a dispensing fee. Okay. But now let's talk about what the insurer now is getting from the pharmacy benefit manager. Pharmacy benefit manager follows a different course, and I'll start at the beginning. The pharmacy benefit manager will negotiate with the pharmaceutical house. So they're negotiating there, number one. Number one negotiation. There's several. Number one negotiation with the pharmaceutical house. How much am I going to pay for that particular drug? What influences that? Well, number one, the list price. The list price. It's always the top list price. But the pharmacy benefit manager says, listen, I've got a number of pharmacies that are in my chain, basically, with X number of people who are getting their prescriptions there. A lot of people who may need your drug, number one. Number two, it's got to be on that formulary. Otherwise, if it's non-formulary, you can't get it through that insurance company. They control the formulary, the pharmacy benefit manager. And on that formulary, they have several tiers of costs of the medication. Tier 1 is what they call the preferred medication. Now, that doesn't mean it's the cheapest, but it's the preferred medication. But they use that as a negotiation with the pharmaceutical house. So they say, well, we have a large number of clients. We have the ability to make up the formulary, put whatever drug you want on which level, preferred, level tier 2, tier 3, non-preferred. Okay. Most of the people will want to purchase the ones that are on tier 1. Okay. So the pharmaceutical house, and in negotiation with the pharmacy benefit manager, will decide, well, these expensive drugs should therefore be tier 1 drugs. Okay. So based on what that pharmacy benefit manager offers to the manufacturer, they will get a specific percentage rebate off the list price. Now you may say that may be a small amount. Oh no. Medicare, for example, for Medicare patients, the rebate from the pharmacy benefit manager, rebate is 30% of the list price, 30% for Medicare. And it goes all the way up to 60%, depending on who is purchasing that drug. So that is a very interesting way of doing it. So that's number one negotiation. Now, based on that, the pharmacy benefit manager then takes that medication and at a very reduced price because of the rebates and all. And also, whatever influences it. I gave you the major reasons what influences that particular thing. So now that pharmacy benefit manager negotiates with the health plan. It's totally separate from the negotiation with the pharmaceutical house. And nobody knows what the contract and each side is. So that the health plan doesn't know what the rebate is, what the price is of that medication that the pharmacy benefit manager bought. Okay. So now they're negotiating now with the health plan. And so how do they negotiate? What are the positives and negatives in that plan? Well, as I said, the pharmacy benefit manager will do the formulary for them and select the tiers in that formulary. They may eliminate a couple of things. It could be very common medications. No, that's non-formulary. You got to pay for it full price, which is that list price up above. So at any rate, their negotiation now to what they're going to sell the health plan, what the health plan is going to pay for that medication. Does the health plan know what the pharmacy benefit manager paid? No. But it's a separate negotiated figure. We will pay you a certain amount. Okay. There may be a big difference in what the PBM paid and what they're getting from the pharmacy. There may be a big difference. Who pockets that? Pharmacy benefit manager pockets that. Okay, so that's negotiation number 2. But that's not the end of it. Now the pharmacy benefit manager has to negotiate now with the pharmacy, because now the pharmacy has to get that medication. They have to know exactly what's covered, what isn't covered, what the tiers are. They need to know all that information except the cost. Pharmacy benefit manager is not going to tell them what they paid and what the health plan is paying them for it. That's negotiation number 3, done by the PBM. Okay. You think that's going to be it? No. All these negotiations are going on, so many that the PBM has to subcontract out to what they call rebate advocates. These guys are slumbags. They are terrible people, but they are great at negotiation. They're like the timeshare people, just horrible people, but they get the job done, and all for the benefit of the PBM, the pharmacy benefit manager. Of course, in their description and all, they're benefiting the poor patient, getting them the lowest price for their drugs, of course. These PBMs have been around for many, many years. They began back in the 1980s. And then in the 1980s and 90s, we began to see generic drugs. And the PBMs were actually doing some good back then because they steered people away from the brand name and into the generic drugs. Since that time, the pharmacy benefit managers have expanded tremendously. And now, with all these kind of hidden negotiations, which one side never really knows what the other side is doing, except for the PBM. And that's how they make their money. And that's how the medical pharmacy benefit works as well. We don't know who they are. Not easy to find out who is the one who's negotiating for your particular medication. You can find out if you persist, but it's not easy. Okay, let's go on from there. You would think that would be about it, but it isn't. It isn't. Let's talk for a moment about what some of these things, the players, the actual players in all of this nonsense. Well, first of all, we can talk about how the PBMs will make their money, basically. How do they make their money? How do they make their profit? Well, number one, they keep all these negotiations are one-sided. One side, that side doesn't know what the other side is doing. So that's number one. No transparency, basically. And that's at multiple levels. Number two, nobody knows except the PBM what the amount of the rebates are in each of those. Because there's rebates going both directions in all these negotiations. Because the PBM is holding the cards. They're holding a good hand. Because they control that formulary. And they now use vertical integration. They've expanded up from just being a plain PBM. They now own pharmacies. They now own insurance companies. Actually, the insurance companies own the PBMs, the major insurance companies. Roughly, the top 4 insurance companies own roughly about 80% of all of the prescriptions, basically 80%. And the top 6 of the insurance companies own roughly 90%. So it's a lot of prescriptions owned by just a few conglomerates of the insurers. We all know who the insurers are. It's the Cignas, Aetna. Blue Cross Blue Shield is not one of the top 3, incidentally. The top 3 are the Aetna, Cigna, and Optum. Those are the 3. United Healthcare. Those are the 80% of all the prescriptions. And now the PBMs. Who are the major PBMs out there? Well, the major PBMs out there right now, at any rate, are basically not just formulary managers, not only the negotiators of the rebates and discounts, not only do they own some of the pharmacy networks, but they will also negotiate to add on to that whole network. They do all the claims processing in there. So if you're going to complain, the claims go through them. They also provide clinical management services to the pharmaceutical or to the insurers who have negotiated with them to be with them. So that is how they control, total control of the drug cost. And with that prior authorization, they can control the procedures that are done as well. They say on paper that control is necessary to keep the cost down. Yeah, it keeps the cost down. But a lot of these people are not even doctors. They're people who are part of the non-physician group that controls the physician group, basically. We used to call them the shirts versus the grunts. The ones who have the clean shirts never get their hands dirty, all behind the scenes, and the grunts who actually have to do the work and face all of the complaints, etc., themselves. Well, it's no wonder that there's a lot of burnout, why there's so fewer primary care doctors now, why you're paying more, not just for the prescription, but for your health care benefits. Remember, $14,000 is the average that we pay. And so it is unbelievable. So we get back to that vertical integration. You got a number of different steps along the way that now are part of the pharmacy benefit management group. All these. But these are all in network. You've heard that term before. You have to stay in network in order to get your best price. If you're not in network, you're going to be paying full price, which is the list price. Okay, so remember that. I always follow the money. That is the way to do it. Follow the money. When you look at the salaries that these people are making, we always blame the pharmaceutical houses. Oh, you're making loads of money, you're crazy. Well, there are a couple of crazy CEOs that will up a price of 3,000-4,000% for a drug. They're out there, but the majority are not. We always look at the Pfizer, which is the biggest one, basically, because they were in the paper so much because of COVID and their vaccine and all. But in fact, their CEO is the highest paid CEO of all of the pharmaceutical houses as well. I believe in 2023, $16.1 million. Now, he'll tell you, well, it was only $1 million something for a salary. Yeah. But what else are you getting besides that one salary line and all? You're getting some benefits as well. You're getting stock equity every year. That stock equity that they get on an annual basis is probably 10 times the salary. In fact, that's what it is with the person who's the head of the Pfizer. And it's also true of the people who are the head of United Healthcare as well. Big bucks with the stock options. And of course, they get a bonus every year as well. That bonus is more than you would make probably in 10 years with your salary. So, at any rate, when you follow the money, you know where it's going. Now, the wholesaler does make some. And there are 3 major wholesale distributor combinations that are the biggest in the country. You're probably familiar with a McKesson. McKesson does produce a lot of they have huge warehouses. They have a lot of the medical equipment and supplies. They have a huge catalog that you can order from. But they also are wholesalers for the pharmaceuticals as well. Now, by the pharmaceuticals, what do I mean by that? Well, there's the brand name drugs, there's the generic drugs, there's the specialty drugs, which are basically the high-priced biologics. Biologics just mean it's made from a living organism. That's all that means, a biologic. And then there's biologic equivalents. Those are the so-called, like the generics of the biologics. So, and they all have specific regulations that they have to follow. But that's in a nutshell what they are. And so, let's go on. We talked about the vertical integration. What does that do, that vertical integration? Well, first of all, it guarantees preferential treatment for people who belong to that vertical integration. That's why the PBMs are getting larger and larger and larger all the time. In fact, there's some states that have, I think Arkansas, I'm not sure, Arkansas or at least one state has passed a law saying that PBMs cannot purchase a pharmacy. They cannot be a pharmacy in that state. It's been on the docket for federal stuff for years. Never gets out of committee. Why? Why? Simple. Follow the money. When you look at what one of those companies, one of those insurers, let's take, for example, United Healthcare. What do they pay out to all of the politicians per year? Hundreds of thousands of dollars spread, not just because of they're Democrat or Republican or independent. They all get money, all of them, not just federal, but state senators that also participate in getting some money into their political action committees. Several 100,000 from one company per year. And so when you count up all of the different companies, that's big bucks. That's why it never gets through Congress. It's terrible, terrible. So preferential because of the vertical integration and a support from Congress. Number 3, unfair contracts. A lot of the people who sign these contracts, the smaller ones especially, they have no idea what they're signing sometimes. You say, why not? Believe me, it's not simple. And so they sign a contract and now they're constrained by it. Number 3, these negotiated rebates. Like I said, you've got these people who are like the timeshare salespeople. They are ruthless, and they get the best price for the PBM. Then finally, there's some exclusions in the pharmaceuticals. All of a sudden, a drug that somebody has been on for years get taken off a formulary. It's non-formulary now. Well, nothing you can do. You can't get it through us. Well, can I still get it? Oh, you can still get it. Pay the list price. Oh, shit. That just happened to my wife. She'd been on Dilantin for her seizures for years. 40 years. Dilantin, the only thing that worked. If she got onto the generic, she had a seizure because there's different stuff in each of those capsules. Yes, they do have the active ingredient, but there's a bunch of other things. There's fillers, binders, colors. All that stuff is together in that capsule. She could not take them. It got absorbed by all of the proteins that are out there, grabbed the stuff. It never elevated the Dilantin level. She has to have the brand name. All of a sudden this year, off formulary, non-formulary. Been around 50 years. Take it off. You got to pay for it now. Pay double what we paid before. So that is exclusions in the formulary. And it goes on a lot. Now, a lot of the PBMs make their money with specialty drugs as well. In fact, they may be the most profitable of all of the different drugs. Not just the brand and the generics, but the specialty drugs, they can really control the price of those things. Last year alone, a number of them went up almost 2,000% in cost. Translates to roughly $4.8 billion just in the specialty drugs alone. And now they're also controlling the mail order drugs as well. So that's all part of the network, which is basically the network and all of that vertical integration. Okay. I know it's a lot of material to absorb, but let's face it, they're all making money. They're all making money off the drugs. And who is paying for it? You. You wind up paying for it. Higher premiums. Eventually, you're getting more denials on what you can take. You're getting also decreased healthcare providers. Well, I hate that term providers, but there's a decrease in the number of doctors because they're burning out, because they're spending half their time doing paperwork, which is not really pertinent to their patient. If you want to get them to sign one, let's say that we've got some medical necessities. You've got to have these things. Well, if I've got to have them, I should be able to take them off my income tax if I've got to have them, like say a staircase or a stair lift or whatever you need. And you paid several $1,000s. I should be able to write that off on my income tax. Try to get a doctor to sign the medical necessity form. First of all, most of them don't even write the damn thing. They have somebody in an office who will write it out for you. He'll sign it. Come on. That's the ridiculous state of affairs as it is right now. So I'm kind of just frustrated. I'm burned out. But there's a lot of potential legislation that's out there. Will it ever get passed? Well, as I told you when we talked about the amount of money that goes into all of the pockets of all of the politicians, it may never get out of their committees. So, good luck with that. Okay, this is Dr. C. I'm pooped. Have a nice day.